think we should back up for a moment and just say the goal of therapy is to prophylax patients and ideally that they wouldn't have any nausea and vomiting. And we know we're not quite there yet. We've made a lot of progress, certainly in the acute, as you've all mentioned, and the majority of patients now don't have acute nausea or vomiting. We still have problems with delayed, which we'll talk about at some length. But let's talk about the different guidelines that are out there and how they differ, how they're alike. Charles, can you lead us off on that?
Yes, I won't finish because there's a lot to talk about there, but I'll get things started with this thing. So there are guidelines around. They've been around for quite some time. There are ASCO guidelines and MASC, ESMO guidelines. They weren't; those are together now. They weren't in the past. There are ONS guidelines. There are NCCN guidelines, and they have a lot of similarities.
Right.
A lot of similarities, and basically, the idea is to try to prevent nausea and vomiting at a reasonable cost. I mean, if you said you want to prevent all nausea and vomiting, then you do minimally emetogenic chemotherapy. You'd give the whole bunch, but that's, again, very expensive, and we have to think about that aspect of things. So the different chemotherapies are rated in terms of minimal, mild, moderate, and highly emetogenic chemotherapy. And also for most of the highly emetogenic chemotherapy, an NK1 receptor antagonist, say 5-HT3 receptor antagonist, and dexamethasone are recommended by basically all of the guidelines there. If you get down to moderately emetogenic, then a 5-HT3 receptor antagonist and dexamethasone for sure, maybe not the NK1 receptor antagonist, and probably using the palonosetron version of the 5-HT3 receptor antagonist because of its prolonged half-life there. In that setting, if a person chooses to use an NK1 receptor antagonist, then a lot of the guidelines say, well, you don't have to use the more expensive palonosetron because you have the NK1 receptor antagonist on board there. Now, the one guideline that kind of jumped the gun a little bit, if you will, NCCN guidelines have added a while ago, a year or so, olanzapine to the mixture, and I think we might talk about that later there. And where the other guidelines have not, but they're talking about and they're starting to and all that, because that is a new player on the block.
So if I could just interject a little bit about guidelines. Guidelines are wonderful, but they're only good if they're used. And, you know, they're simply that, they're guidelines, and each institution can incorporate the guidelines as it fits their particular institution. We're hearing a lot about adherence these days, difficulty in physicians and practices actually following guidelines, and what do we do to help that or alleviate that? I think there are a few things that we can do that many institutions are already doing, and that's to have standardized orders, using electronic medical records that have the guidelines already incorporated into each chemotherapeutic regimen, so there's less of a chance to order the wrong thing, if you will. But adherence, I think, is a major issue, and we're really sort of looking at that from lots of different angles.
Yeah.
I mean, go ahead.
Yeah, so I mean, I think that's right on, and I had a chance to review an old paper I participated in sometime that went back to when we first developed our antibiotic guidelines in 1995, so 20 years ago. We did set up, the nurses figured out grade 1, 2, 3, or 4 emetogenic chemotherapy, and then we have what you give for each one of those, and it's set up so when you order the chemotherapy, that comes up. Right. The doctor can change it, but it's easier not to change it, and you don't have to remember which is a moderate emetogenic regimen and that sort of thing. We actually have 5 grades for very highly emetogenic, i.e. if you do poorly with your highly emetogenic and your next go around, then you jump up a thing where we actually add in the NK1 receptor antagonist and palonosetron in that particular setting for that, or if we're given cisplatin and radiation, you know, that because that caused so much trouble. We recently were able to look at that and say, you know, does this, it seems like it should help with people using the guidelines, and we actually went and looked at it with Kunal Kanakia, a fellow that I worked with there, and found that 95% compliance is what we did. And in the few chances where it wasn't, it was because of a drug interaction sort of thing, so it was good. It wasn't 100% compliance, but that is a way that you can, in fact, do that and make it happen. It's a bit clumsy in ways because what if you want to change this and that? It's not easy, and you might not have the other drug on the formulary, and to get the whole institution to change things can go through a process, and let's double check and ask the pharmacists and the nurses and all those processes. But it does work quite nicely in that setting.
So that's the Mayo Clinic, and you're the standard that we all aspire to. But we do know that in practice, despite the fact that almost everyone has a health record today, we don't use the guidelines. And it's curious to me that, particularly as it comes to supportive care, sometimes they're not used if they're built in. And if we don't build them in, then we're even further off guidelines.
Right.
What's been your experience?
That's been our experience, and certainly it's been well published now that the adherence to guidelines isn't great. But if you do adhere to the guidelines, outcomes are much better. And so we have leaned on technology and EMRs to build things in. And pharmacy was a big player, at least our institution, along with medicine and nursing. So we do build them in now, and so our adherence rates have been much better, for sure.
I think it also highlights the role of the pharmacist and the nurse, because the oncologist now, with all these new drugs that we get an email each day about a new drug approved, and it just the amount that we're all responsible for. So I'm finding that pharmacists are really helping set these orders up so that's most efficient for physicians. And really, our trainees, I don't know, Lee could probably comment on this. When I have talks with my fellows about highly metagenic chemotherapy, heck, I start off the talk with what the heck is heck? Because very few fellows even know what the different categories are and how to approach them. And those days of writing out orders and actually knowing them and learning them by writing them out are just gone.
Yeah.
So there's something to be gained, certainly the standardization when the pharmacist is doing it, but there's also something to be lost because you don't remember, as the oncologist, and you are doing the initial ordering, exactly what's in that whole very complex care plan that we have now. I want to go back and talk, because of this, I want our audience to be fully aware of sort of the way that the guidelines are set up and the categories. So they're all divided into acute and delayed recommendations. Eric, you want to mention a little bit about those differences?
Yeah, so I think, acute, we just decided, it's defined arbitrarily as less than 24 hours, and we're stuck with that based on cisplatin. And then delayed is the 24-hour period up to about 5 days. Again, when we're thinking about acute, we know that the 5-HT3 receptor antagonists have a much larger role, and then with the delayed, the NK1 receptor antagonists. I think that's what you're trying to get me at.
Right, let's talk about the use of Decadron as well.
Yeah, so we have emerging data actually. The common question for people when I talk about this is, dexamethasone. Do I need to give it for the full 3 days in the delayed phase? And even at ASCO this year, there's a poster describing, day 1 dexamethasone might be enough. And any pharmacist, when I talk to them about this, they kind of laugh because we all know the biologic half-life of dexamethasone is 36 hours because it's fluorinated. Yet history has been that we've included it, and it could be that we're just finally at a point in history where we have such good tools with the 5-HT3 receptor antagonist and NK1 that we can start to say, hey, do we need to give dexamethasone and give our patients all these side effects for those days?
In a breast cancer practice, and I'm interested in your thought too, Charles, but as particularly where we give a lot of dose-dense chemotherapy, if we have to give 3 days of dexamethasone every 14, that's a lot of corticosteroids. And the women don't like it, and they have lots of issues, as all people do, with getting hyper and diabetes flaring and so forth. What's been your experience?
Yeah, so I agree with you, and I've come down, there's this ASCO abstract this afternoon supposed to be presented, and there are other papers that have come out recently that suggest that you can get by with just day 1 dex. And my own philosophy, give them 3 days of it, a scripture. If you have no nausea and vomiting on day 1, then you're probably going to do fine.
Yeah,
if you have nausea and vomiting, then probably take day 2 and 3.
Right.
Is how I've come down on that.